Thank you, Beth. I also wanted to thank Dr. Kinney and Dr. Sharma for the opportunity today. My name is Aldina Radoncic. I am a current cardiac cath lab nurse here at Mount Sinai, and I've been here for 3 years. And today I'll be talking to you about ensuring safe transfer from the cardiac cath lab to step-down unit. Just a non-disclosure slide. So this presentation, I will focus on key goals on how we manage patient care during transitions between settings. We will examine how to assess patient readiness for transfer, support safer transitions through structured communication, and maintain continuity of care across teams. In addition, I will discuss strategies to prevent complications and explore how standardized post-procedure monitoring can help us quickly identify and respond to early changes in patient status. So this emphasizes aspects of the nursing role in safe transfer from the cardiac cath lab to step-down unit. The transfer process starts with a thorough pre-transfer clinical assessment. This step ensures that the patient is clinically stable and ready for transfer. It involves reviewing hemodynamics, access site, and neurovascular checks. Once the patient is cleared for transfer, the next step is ensuring effective communication with the receiving team. The nurse then gives handoff to the receiving unit where key clinical information is communicated to the team. After handoff, the attention turns to coordinating the transport of the patient. The patient is accompanied by the nurse and the patient care associate. We connect the patient to a monitor and have emergency medication and equipment with us for transport. Once the patient arrives to the receiving unit, the nurses verify the patient clinical status. We compare it to the pre-transfer assessment and identify if any changes have occurred during the transfer. As I discussed the process of transferring patients post-PCI, it's important to look at the key risk factors that can compromise patient safety during these transitions. Before I review the specific risk factors, I wanted to define transitions of care by the Joint Commission, which is a focus in patient safety initiatives. The Joint Commission defines transitions of care as a movement of patients between healthcare practitioners, settings, and level of care as their condition and care needs change. As these transitions are well known to be vulnerable time for patients, there is a need for more effective and safe approach to continuing patient care. Looking at the risk factors in the transfer process, first is breakdown and handoff communication. This can directly impact patient care in the receiving unit, where the team is depending on accurate information to guide monitoring and interventions. This risk also increases when there are multiple handoffs involved in the transfer process. Frequent handoff between clinical staff introduces more chance for communication gaps because every additional handoff is an opportunity for either miscommunication or loss of information. Even with good communication, we also must pay close attention to how consistently patients are being monitored. If patients are not being continuously monitored and observed before and during the transfer, subtle changes in their condition may go unnoticed. There is always a chance that the patient can become unstable during transport, and that could be due to either the patient not being fully stabilized prior to transfer or there was an unexpected change. This is why cardiac monitoring, having emergency equipment with you, and having a nurse there during the transfer process is important for maintaining patient safety. Trying to go to the next slide. Thank you. So a key part of ensuring safe transitions of care after a coronary intervention is determining which patients are appropriate for the step-down unit, which here at Mount Sinai is our post-cath unit 7 East. The patients should be hemodynamically stable. This means near normal baseline vital signs with no signs of instability, which is confirmed through a thorough clinical assessment before transfer is considered. Patients that have undergone complex interventions, some examples such as left main PCI, bifurcation stenting, or the use of a rotational atherectomy device, can still be admitted to the step-down unit only if those procedures were completed without any intraprocedural complications. If there were any complications during the PCI, such as vessel perforation, arrhythmia, or any major bleeding, the patient most likely would remain at a higher level of care for closer observation. If the patients also require any titratable vasoactive infusions such as epinephrine, have unstable airway or require mechanical ventilation, or require invasive hemodynamic monitoring such as an arterial line, or support devices such as an intra-aortic balloon pump, the patient would not be appropriate for step-down. Once the patient is deemed stable and appropriate for the step-down unit, the next step to ensuring safe transfer is how we communicate during handoff. So structured handoff plays a vital role in ensuring patient safety during care transitions. The Joint Commission has made this a top priority through its national patient safety goals on safe handoff communication. Their guidance emphasizes that during transitions, we must ensure the transfer of accurate, timely, and complete information every time. The national patient safety goals were created because data showed that inadequate handovers are a contributing factor in 80% of all adverse events, which include wrong site, wrong procedure, treatment delays, medication errors, and falls. Structured handoff also ensures continuity of care by transferring information clearly and consistently between clinical teams. Structured handoff as well also promotes clinical accuracy and safety. This helps us address issues early, able to also prioritize patient needs and deliver safer care. So the Joint Commission outlined 8 tips that strengthen the safety and quality of handoffs. Overall, it is about ensuring that both teams actively participate during handoff and that the information being shared is complete, clear, and current. Using a structured, standardized format such as SBAR, which is a standard here at Mount Sinai, is an effective tool for ensuring structured and consistent communication during handoffs. It stands for situation, background, assessment, and recommendation, which provides a guide to help ensure all critical information is communicated. It is just as important to also create an environment where questions can be asked and clarifications made. Altogether, these strategies reinforce communication and promote seamless, high-quality transitions of care. So this is a structured handoff tool that we use here in the cardiac cath lab. The core components of our handoff tool always begins with patient identifiers, name and date of birth. It's the first safety check to make sure we are talking about the correct patient, especially in a busy environment. Allergies and code status comes next, followed by giving a clinical summary and history of why the patient came to the hospital. Then building on that, we share the diagnosis and what we found during the procedure, which could be 1 vessel, 2 vessel, 3 vessel coronary artery disease as examples. We then outline exactly what interventions were performed. Next, we provide details about the vascular access site. We specify which access site was used, as example, radial or femoral approach, which guides vascular checks, mobility precautions, and helps prevent access site complications after transfer. We make sure the receiving team is clear on what comes next for the patient. Post-intervention orders are communicated clearly, including medication, monitoring instructions, and any follow-up appointment and tests. So the immediate post-procedure period within the first 6 hours is when patients are at their highest risk for major adverse cardiac events. And that risk window is important for how we approach monitoring and communication during transfers. Trials such as SAFE PCI and EASY have shown strong support for observing patients closely for 4 to 6 hours after uncomplicated PCI. And current ACC and SCI guidelines align with this time frame as well. So how do we translate this evidence into practice within our hospital? We do it through a structured time-based monitoring protocol. We follow the structured post-PCI protocol to ensure that we detect complications early, and which may include access site bleeding, stent thrombosis, arrhythmias, or hemodynamic instability. For the first hour, we assess our patients every 15 minutes. The second hour, we assess our patients every 30 minutes, and then every hour for the subsequent 4 hours. This approach gives us frequent assessments early on when risk is highest, which is consistent with the guidelines. It is also important to note that this protocol continues even after transfer to the step-down unit, ensuring true continuity of care and maintaining a strong patient safety net throughout the recovery period. Before I end, and to wrap it up, I'd like to leave you with one key takeaway point, which is by prioritizing structured communication and vigilant post-procedural monitoring, we can significantly enhance patient safety and ensure successful transitions of care. Thank you so much for your time.